I'm Thomas Baldrick at ATS 2015 in Denver. This is Dr. Ron Oudiz, Professor of Medicine and Director of the Pulmonary Hypertension Center at the Harbor UCLA Medical Center. Sir, thanks for stopping by.
Thank you for having me.
So you just came from the Ambition trial presentation. First, tell us what that was about.
Well, this was a presentation of the subset of patients that were met the exclusion criteria for Amendment 2, which was designed to filter out patients that had a higher risk of diastolic dysfunction. That is, patients, for example, that had atrial fibrillation, or their body mass index was high, or they had diabetes or coronary disease. And the purpose of that amendment was because of the fear that these patients really weren't classic idiopathic or associated PAH patients, but rather they had higher risk of having diastolic heart failure and having PA pressure elevated for that reason. And so what we saw in this analysis was a determination of whether or not those patients in fact did benefit from combination as opposed to pooled monotherapy, and if there were any circumstances that sort of predicted why they did or didn't benefit. And it turns out that the primary endpoint, the reduction in the primary endpoint, was very similar in that group of patients that were not part of the primary analysis subset. And there were two areas within that group, two secondary endpoints that were a little bit suspicious in terms of whether or not they would have met or hit the secondary endpoints. One was the change in 6-minute walk for those patients that met the exclusion criteria that would not have been allowed to be enrolled after Amendment 2, seemed to have a blunting in the change in exercise capacity. And as well, there seemed to be a blunting in the change or the reduction in B-type natriuretic peptide. So although those were secondary endpoints and this was a post hoc analysis, there is at least hypothesis generating data that suggests that those patients who don't fit the classic profile of PAH might not derive the same benefit in those two endpoints.
So what are the implications of a subset analysis?
Well, that's actually probably the most relevant question one would ask after digesting the data from this study, because we worry that clinical trial patients are different than real-world clinical patients in the office or in the hospital. And this, I think, this analysis, the fact that those patients, despite the fact that they may not have fit the classic entry criteria or the classic definition of pulmonary arterial hypertension, still derive benefit from the primary endpoint. And therefore, I think we can go on to say that, in fact, combination therapy can be extrapolated to real world, and that at least for patients that we're seeing in the clinic that fit the criteria for PAH who are newly diagnosed, they benefit better from combination therapy up front than they do from monotherapy with add-on later on of a second therapy.
Anything else you wanted to add from it?
So going forward, in terms of trial design, clinical trial design for PAH trials, it brings up the question of whether or not we really do need to enrich our patient population and exclude patients who might not fit the classic definition of IPH, or at least who have a higher risk of having diastolic heart failure as the cause of their pulmonary hypertension. And if you're doing a long-term outcome trial, maybe not. However, we can't all do long-term trials for new drugs that are being developed, and therefore if we're using endpoints like 6-minute walk or BNP, we probably would do well to be careful and exclude patients who might be at risk for blunting that endpoint, meaning those patients that have a higher chance or higher likelihood of having diastolic heart failure as the primary cause or contributor to their pulmonary hypertension.
Doctor, thanks for stopping by and sharing your insights. We appreciate it.
Thank you.